It's a pleasure to be here in Portland tonight, especially since in Vancouver tonight it's the opening of the Winter Olympics, and the orgasmic hype is about to reach its highest level probably as we speak here tonight, and it's really great to be away from that stuff. The facility where I've worked for the last 12 years in the downtown east side of Vancouver, which is known as North America's most concentrated area of drug use, it's called the Portland Hotel. It's actually named after Portland because it's based on some programs for street people that originated right here in your city. So it's a real pleasure to be here. The Portland Hotel is not a hotel, it's a domicile for people that otherwise would be in the streets. In fact, the average person in the Portland would have had 5 or 6 addresses in the previous 12 months before being admitted to the Portland. And that's where my clinic has been for the last 11 years. For the past couple of years, I've been working at the supervised injection site, as Nick mentioned to you. I'll begin by reading from the 2nd chapter of my book, and what you will see is that I'm not a very successful doctor. My patients don't live very long. They die of, as in the case of the woman whose story I'll read you a little bit, they die of overdose early in life. They die of HIV and its complications, of hepatitis C, of multiple infections of the heart valves, the spine, cancer of the liver, suicide, and violence. The chapter 2 is entitled The Lethal Hold of Drugs, and it opens at a funeral home with a memorial service for a patient of mine whose name was Shannon. I called her Sharon in the book. And the epigraph to the chapter is by the great Egyptian novelist Naguib Mahfouz, who in his Nobel Prize-winning Cairo trilogy wrote, "Nothing records the effects of a sad life so graphically as the human body." From behind his lectern at an East Hastings funeral chapel, the elderly priest proclaims the world's farewell to Sharon. How exuberant and joyful she was. "Here I am, Shanana," she announced as she burst into her room. On seeing her, who could not feel glad to be alive? Behind the family, the mourners are dispersed throughout the sparsely filled chapel. A group of Portland staffers are present, along with 5 or 6 residents and a few people I don't recognize. The young Sharon, I've been told, was model beautiful. Hints of that beauty still remained when I met her 6 years ago, well now 10 years ago, traces gradually erased by her increasingly pallid complexion, sunken cheeks, and decaying teeth. In her last years, Sharon was often in pain. 2 large patches on her left shin were denuded of skin by injection-induced bacterial infections. Reinfection caused repeated skin grafts to slough off, leaving the flesh continually exposed. The exasperated plastic surgeons at St. Paul's Hospital considered further intervention futile. In her chronically swollen left knee, a bone abscess lurked, flaring up every so often and then subsiding. The osteomyelitis was never fully treated because Sharon couldn't endure the 6 to 8 weeks of hospitalization required to complete the intravenous antibiotic regimen, not even when it appeared that amputation might be the only alternative. Unable to weight bear because of inflamed knee joints, Sharon became hostage to a wheelchair in her early 30s. She propelled along the Hastings sidewalk at astonishing speed, employing her strong arms and her right leg to boost herself along. She went to a detox and a rehab center for 6 months. Something snapped. She came back to the downtown east side, and within a few weeks was found dead of an overdose. I will skip the details of the funeral service, and I'll just go to the parking lot outside where after the memorial event, a few of us gathered just to say hello to one another and to console one another. I look at this small cluster of human beings gathered at the funeral of a comrade who met her death in her mid-30s. How powerful the addiction, I think, that not all the physical disease and pain and psychological torment can shake its lethal hold on their souls. Nothing sways them from their habit, not illness, not the sacrifice of love in a relationship, not the loss of all earthly goods, not the crushing of their dignity, not the fear of dying. The drive is that relentless. How to understand the death grip of drug addiction? What keeps Penny injecting after her spinal abscess that nearly made her paraplegic? Why can't Beverly give up shooting cocaine, despite the HIV, the recurrent abscesses I've had to drain on her body, the joint infections that repeatedly put her in hospital? What could have drawn Sharon back to the downtown east side in her suicidal habit after her 6 months getaway? How does she shrug off the deterrents of HIV and hepatitis, a crippling bone infection, and the chronic burning, piercing pain of exposed nerve endings? And this is where we need to lay aside the mythology around drug addiction. The first, that addiction is any kind of a choice. Now, there's a new book by a Eastern Seaboard academic psychologist recently called Addiction, a Disorder of Choice. And this is the kind of nonsense that academics could publish, don't have anything to do with the real world. Because who actually in the real world would choose to get hepatitis and HIV and be ostracized, marginalized, be ill, be impoverished? So choice really has very little to do with it, but the hypothesis of choice serves a very useful social function in that it takes the onus of society, and it takes the onus of us as a culture to look at ourselves as to what is it that engenders addiction in the first place, and what social responsibility is there for treating addicts in a different way. So the choice one can be laid aside right away. The second myth that we can really forget about is that negative consequences somehow are needed to impel the addict to give up his habit. I mean, what negative consequence have my patients not already endured with all the diseases and other miseries that befall them and blight their lives? This assumption that people have to hit rock bottom before they will move towards recovery, again, needs to be laid aside. There's no end of rock bottoms and negative consequences that people won't endure for the sake of their addiction if they see no alternative. The real question then is not what's wrong with addiction, because it's clear what's wrong with it. I mean, it's obvious. But what is it that it does for people? What need does it serve in such a way that people aren't able to give it up? And here's where the words of Dr. Vincent Felitti, who's an American researcher and medical doctor, really are profoundly wise. And Felitti wrote, "Dismissing addictions as bad habits or self-destructive behavior comfortably hides their functionality in the life of the addict." In other words, what is the function of the addiction in the life of the addict? Now, from the strict medical point of view, the answer is obvious. Now, when I say the medical point of view, I'm speaking from a very narrow medical point of view. I'm a medical physician myself, but I can tell you that the medical perspective on most things, let alone addiction, is way too narrow and way too limited. And not even when it comes to the straightforward medical diseases like cancer and rheumatoid arthritis and multiple sclerosis and or asthma or any number of medical conditions, does the medical view provide a broad enough perspective? When it comes to addictions, it's a hopelessly narrow perspective. But it doesn't mean that it doesn't have its value. So from the strict medical point of view, what happens with addictions? Well, clearly, all addictions are a form of self-medication. If you look at the particular conditions that the addictive drugs treat, what are they? Well, recently there was a study based in Iraq that showed that people, American soldiers, after an experience that is extremely traumatic, if they receive morphine quickly after the episode, they're less likely to develop post-traumatic stress disorder. So there's some connection between the opiates and PTSD. And so clearly a lot of people with addictions are self-medicating PTSD, and as to why they should have PTSD, post-traumatic stress disorder, I'll tell you about it in a moment. People self-medicate depression. You know, the antidepressants, the SSRIs like Prozac, which elevate serotonin levels in the brain, which is an important chemical, brain chemical, important in modulating moods. Well, cocaine, amongst other things, also blocks the uptake of serotonin like Prozac does. It makes serotonin available, therefore it's an antidepressant. So people self-medicate depression.